Respected teachers, seniors and colleagues, welcome to the third session of our journal club by IAP Thiruvanaanthapuram. So today is a very special day because we have very eminent teachers among us, and it will be a great experience listening to them. As we all know, IAP Thiruvanaanthapuram has started this journal club with the aim of increasing the updation of our IAP members. So the articles selected are usually from national and internationally indexed ones, and it should be also be useful to the postgraduates who are appearing for the examination and all. We are trying to keep our best to keep the quality, and we are trying to do that in a regular basis and all. As a routine, I would like to welcome all to this session of Journal Club. I have Dr. V.July sir, the state IAP president, has agreed that if time permits, he will join. I welcome him. And of course, Johnny Sebastian sir also, Kerala secretary. He has also told me that he will also join if time permits. District President Madam is now she's out of station. Dr. Rubini Madam, I welcome her also. She will probably join. And Sibi Kurian, our secretary, Dr. Sibi Kurian, he will also probably join. And I'll also like to welcome the other faculties to this session, especially our beloved teacher, respected Dr. Zulfikar Ahamed sir, Dr. Ramankutty sir, Dr. Aiswarya sir, Padmanabhan sir, our journal club coordinator, the postgraduates who have been working on this and will be presenting today, and all the respected seniors, colleagues and teachers among the audience. As an opening, I will like to request Dr. Padmanabhan sir, the coordinator of the journal club, to give the opening remarks. Dr. Padmanabhan sir.
Normally, I don't like to talk much because when you are the listener, you don't like listening to too many. Am I audible?
Yes, sure, sir.
Okay. പക്ഷേ ഞങ്ങൾ ജേണൽ ക്ലബ്ബ് തുടങ്ങുന്ന രണ്ടു കാര്യങ്ങളുണ്ട്. ഒന്ന്, എൻ്റെ പ്രാക്ടീസിൽ എനിക്ക് തോന്നിയിട്ടുള്ള people will now say the doctors are very, very lucky. They got lot of access to things. But the problem now is what to believe. And let me tell you that in the IAP forum, IAP textbooks, IAP books, there are a lot of errors that are written, which are affecting the practice of doctors tremendously. About gradually, doctors should know to go to the primary source. Primary source. If our practice changing, like for example, asthma salbutamol matram kodutha pora and kuda steroid kuda every acute attack nu parnu gene parayumbol adu nammal vishwasikano adho mattulla guidelines endondu maarunnilla. And the primary source is poi kandupidikkanulla oru capacity doctors ne develop cheyadu. Adu namukkilla, ee generation illa, probably we don't require it. But the next generation of PG should be able to do it. Adu oru valiye ullu. Avarka primary source ipo accessible aanu, more and more accessible. Adu vaayichu nokki adilulla details, adu epidemiologically ellam nadatti ayine etramatram value aa evidence nu kodukkannu manasilakan sadhikkum. Ennamale you will graduate into a good doctor. Illegi innu varanam kekkum, naala veronu kekkum, naala pulmonologist parayunnu kekkum, naala cardiologist paranju adukonde njan digoxin koduthu, iyal paranju adu koduthu. Anganeyanu ippathe PGs practice cheyunnathu. Anganeya sare ഞങ്ങളുടെ അവിടെ പ്രാക്ടീസ് ചെയ്യുന്നു. That is the classical stating. അത് അടുത്ത ഡോക്ടർ പറയും അല്ല ഞങ്ങളുടെ ആശുപത്രിയിൽ അങ്ങനെയല്ല. കാര്യം പണ്ട് SIT-യിലും കൂടിപ്പോയ ഓൾ ഇന്ത്യ ഇൻസ്റ്റിറ്റ്യൂട്ടിൽ നിന്ന് പ്രാക്ടീസ് വരുന്ന ഡോക്ടർമാരെ ഉണ്ടായിരുന്നുള്ളൂ. ഇന്ന് PGs എന്ന് പറയുന്നത് tens of hundreds of institutions വരുന്നവരും അവരെല്ലാം അവരവരുടെ ഇതിൽ ട്രെയിനിങ് എടുത്ത് നല്ലതാണ് കറക്റ്റ് എന്ന് വിശ്വസിക്കുന്നവരുമാണ്. അതുകൊണ്ട് gradually we will have to go to the primary source and believe. And many times the speakers, even in the IAP forum, is I scratch your back, you scratch my back എന്ന് വെച്ച് പ്രസംഗിക്കുന്നവരാണ്. Quality is not ensured. അതുകൊണ്ട് doctors have to ensure their own quality, and that they can come only if they read the journal. I read the journal, I understand many mistakes, but I don't know to judge. അതൊരു വാസ്തവമാണ്. ഞങ്ങൾക്ക് എപ്പിഡെമിയോളജി ആരും പഠിപ്പിച്ചിട്ടില്ല. അതുകൊണ്ടാണ് ഇതിനെ ഒരു എക്സ്പേർട്ട് ആയിട്ട് രാമൻകുട്ടിയെ തന്നെ ഞാൻ വെച്ചത്. I was very particular about it. ഇത്രയും പറഞ്ഞുകൊണ്ട് I hand it over back to, shall I give it to Zulfi, who is talking next?
Sir, thank you, sir. Yeah, Sulfi sir will be giving an introductory remark as far as this journal club is concerned. Before we go to the session proper, we will not waste any time. But I think there are new PGs, alumni are there, and the teachers are well known to everybody. But we will just give a routine introduction, basically. Tilligil Bhavanmaran Guruvin Negatil, Alangil Avrata Cheritam Vakiwing. That is my teacher, that is why I told those words. And I am humbled and thanking the Almighty for this opportunity to introduce, sir. Sir actually needs no introduction. Dr. M. Zulfikar Ahamed, sir. Now, sir was a former HOD, Department of Pediatric Cardiology, MCH Trivandrum Medical College, SCT Hospital. He was instrumental in establishing the first Pediatric Cardiology Center in Kerala at SCT Hospital, catering thousands of patients and more. And sir was a clinical professor of pediatrician and adolescent cardiology at Child Development Center in Trivandrum, doing countless number of research work and papers, especially regarding obesity and hypertension and interventions. Sir is right now giving the service as a senior consultant in pediatric cardiology, KIMSHEALTH Trivandrum. Sir is a pioneer in pediatric cardiology who has numerous articles published in national and international journals, authored books oriented towards cardiology super specialty. Sir is an astute clinician. It is a final word in dilemmas pertaining to the super specialty with the great interest in congenital heart disease, myocarditis, Kawasaki's disease, rheumatic heart disease, and has been authoring numerous scripts as guidelines for the postgraduates, teachers, and practicing pediatricians. A teacher par excellence with the disciples all around the world in India and abroad, which include eminent cardiologists at medical super specialty hospitals, centers across different countries. Sir makes sure that his students does know what he is expected to know, and is well known to making his classes interesting with the quotations and anecdotes. And there are no enough words to describe him as a great academician, clinician, and as an epitome of humanity. Next, I will like to introduce Dr. Ramankutty, sir. Sir started his career as a lecturer in pediatrics in Medical College, Thrissur, Kerala. Sir is a research scientist at SCTIMST, Emeritus Professor and Professor at Achuthamenon Center for Health Science Studies, Sri Jitradhanal Institute for Medical Sciences. Sir is advisor for the Kerala State Planning Board, is a member of the International Epidemiological Association, supervised PhDs in public health, awarded 5, guiding currently 6, and guided more than 25 master's and PhD dissertations, and fellow of the International Academy of Cardiovascular Sciences, and he's the executive director of the Health Action by People. So I was very interested in our journal club, and he's right there with us from the beginning itself. And a word about our journal club coordinator also, Sir Padmanabhan, sir, presently working as a senior consultant in pediatrics. Consultant pediatrician, he has worked about in different hospitals, his teaching experience in Medical College and IAP, involved in research projects, papers published in index journals, and very active in CME discussions, and has concrete and polite evidence-based reviews regarding various aspects in daily life and academic pediatric practice. And one word regarding our PGs who are presenting. The PG who is presenting the article is Aiswarya Renjith, second year DNB Resident Pediatrics KIMSHEALTH Trivandrum, and the analysis is done by Greeshma Baby Final, DNB Resident Pediatrics KIMSHEALTH Trivandrum. Now we will go to the subject proper, the journal club proper. Just before we hear from the PGs regarding the details of the article which is being presented, I would like to request Dr. Zulfikar sir and share his thoughts regarding the topic. Sir.
Anju.
Sir.
See, the problem with this kind of adulation, which of course is genuine, is that the person receiving this once in a while tend to believe them. That's the problem. Anyway, so, another thing is that Padmanabhan is a very close friend of mine, my senior. Ramankutty is another very close friend of my senior. And about Ramankutty, I would say, see, there are so many doyens, there are so many senior people, pioneers. Then you have the living legends. All these species are there in this medical field, but there are very few intellectuals around among medical field, and probably Ramankutty is one of the very few surviving intellectuals. So with that introduction, I think I will go to this particular topic, which is a very interesting topic, a very crucial topic to not only pediatricians and pediatric cardiologists. Basically, coronary artery is basically the property of adult cardiology. It's their crowning glory, but once in a while, we know that it is also very critical in pediatric cardiology. We have two coronary arteries. Left main coronary artery arises from the left sinus of variable length, divides into a left anterior descending artery and a circumflex artery. Circumflex goes along the left AV valve groove, whereas the LAD along the interventricular groove, which basically supplies the major part of the left ventricle. And the right coronary artery is from the right sinus behind the PA along the right AV groove, it travels. And this is again a very important quotation from the journal AHA 1933 by Bland, White, and Garland. It seems probable in this particular infant, the curious attacks of paroxysmal discomfort were those of angina. So they were describing angina in a 3-month-old baby. And this ALCAPA could present basically as angina, or it can also masquerade as dilated cardiomyopathy and mitral regurgitation. And as Anju was accusing me of being little too much onto the history, but I think it's very important to understand the science. I think it's always necessary to know its history. And the history says that the detailed clinico-pathological finding correlation was done in 1933 in a 3-month-old baby by Bland, Garland, and White, and it's called the Bland-Garland-White syndrome. And the title of this study was Congenital Anomalies of the Coronary Arteries, Report of an Unusual Cause Associated with the Cardiac Hypertrophy, which came in American Heart Journal. The triumvirate is William Franklin Bland, who is also known for his research work on rheumatic fever. Paul Dudley White is considered one of the pioneers in cardiology. And there is Joseph Garland, also a physician. And they produced this paper from Massachusetts General Hospital, US. And this is the most common coronary anomaly in the world, potentially lethal. In infant, it can produce heart failure and sudden cardiac death. Adults, it can produce sudden cardiac death, MR, and heart failure. And unless operated, this is very important, unless operated, survival at 1 year is less than 10%, which means it is even worse or equal to survival of a transposition without surgery. It's a very bad disease, but eminently remediable disease, as you can see later when our postgraduates present their data. And as you know, it produces ischemia, cardiomyopathy, acute myocardial infarction, and mitral regurgitation. And the most important focus is here. This is on surgical management of ALCAPA. Initially, we had one coronary solution. That is, you simply ligate the left coronary artery and hope for the best, so that the right coronary will do everything, which is a difficult process for the RCA to do. Then we have the 2 coronary solution, where you maintain 2 coronary, left and right. And one was by a coronary artery bypass graft. You put an internal mammary artery from the aorta to the LAD or LCA. So you have aorta to LCA connection is retained. Then came the Takeuchi operation. I will just show you the picture of that. And now the answer is the coronary re-implantation. And this has come mainly because of the increasing success of arterial switch operation in transposition of great arteries. So as you can see here, on your left-hand side top, you have the anomalous left main coronary artery. A popular surgery when I was doing my DM in Chitra in the 90s and even 2000, Takeuchi repair was the standard procedure. They put a baffle, like you can see properly, through the pulmonary artery, so that it goes into the LMCA, basically comes through the baffle, and the baffle is connected to the aorta. So the aortic blood goes through the baffle into the coronary artery. And now the latest is, of course, the coronary translocation, which is the definite surgery. As you will see later, the major share of cardiac surgery for ALCAPA would be coronary translocation. And this is Takeuchi, and this is a coronary re-implantation. So you can see the re-implantation before and after. You can see the aorta, you can see the pulmonary artery giving rise to LCA, and this you can see both coronary arteries are arising from the aortic root after a CT reconstruction. So, and this is particular article which our postgraduates will try to do justice to. Aishwarya, I think, will present the paper, and Greeshma will offer her what we call as a comments on this paper. And of course, the expert comments will come from Dr. Ramankutty. And because this is basically a primarily cardiology problem, I would always be open to any questions or comments. Thank you very much. I think I will go with the permission of Anju. We will go to Dr. Aiswarya.
Yes, sir. Sure, sir. Aiswarya, madam, you can start.
I will stop sharing.
Yes, sir. Dr. Aiswarya can start the presentation, can start the screen sharing. Thank you.
Yes, good evening, everyone. Am I audible?
Yes, doctor.
Yes, yes.
Welcome to the Journal Club for this month. I am Dr. Aiswarya, second year DNB resident from KIMSHEALTH. I thank IAP Trivandrum for giving us this opportunity. So, the Journal Club for this month is on long-term outcomes of children operated on for anomalous left coronary artery from the pulmonary artery. The study was done by Thomas A.S. et al. And it was published in the Annals of Thoracic Surgery in April 2022. It is a multi-centric study which was done from various centers in US, the Emory University School of Medicine, Atlanta, Duke University School of Medicine, Durham, University of Louisville School of Medicine, University of Rochester School of Medicine, and the Division of Cardiology and Children Healthcare of Atlanta. So the objective of the study is to examine the outcomes in children less than 18 years operated on for anomalous coronary artery from the pulmonary artery, to examine the long-term transplant-free survival and prognostic indicators after the surgical repair for ALCAPA, and to examine the effect of preoperative mitral regurgitation and left ventricular dysfunction on early and late transplant-free survival. The design of the study is a retrospective cohort study, and the setting is from the Pediatric Cardiac Care Consortium, which is a multi-center US-based registry of pediatric cardiac intervention. Study patients includes children who underwent ALCAPA repair before 18 years of age and who were enrolled in PCCC. The study year is between 1982 to 2003. Inclusion criteria includes children enrolled in PCC who underwent ALCAPA repair before 18 years of age, and the exclusion criteria include children with complex intracardiac congenital heart disease and children who underwent their first ALCAPA intervention outside the PCC. Methods. It is a retrospective cohort study in patients who underwent ALCAPA repair between the year 1982 to 2003 in the PCCC and who were also linked with the National Death Index and the Organ Procurement and Transplantation Network to examine their long-term outcome. So this is the flow chart representing the study. So the initial PCC cohort with the ALCAPA repair included 330 patients. But from this, the NDI eligible patients were 288. And from this, the linkage between the PCC and NDI was obtained only for 177 patients. And hence, only these patients could be followed up for a period of 30 years. In these 177 patients, 22 of them had in-house hospital death post-op, and patients who we couldn't follow up, that is the 51 patients whom we could not follow up. In that, 9 patients had death in the post-op period. But the remaining 42 patients, we couldn't get the follow-up data. And amongst the patient, that is 155 patients, when we followed up for a period of 30 years, we found that 147 of them were alive. There were 6 deaths and 2 transplants. Now, the transplant-free survival was calculated from the index hospital discharge to the heart transplant or death confirmed in PCCC, NDI, and OPTN. And the longest possible follow-up is till December 2019. The survival was estimated using Kaplan-Meier survival plots. The survival comparison by surgical strategy or specified clinical variables was done using Wilcoxon log rank test. The effects of the covariates were presented as odds ratio and multiple variable adjusted odds ratio with 95% confidence interval. And the analysis were performed using SAS 9.4 software. The results. Now, the number of children who underwent repair for ALCAPA were 288 from 37 US centers. Of this, 85 were male, that is 37.3% of the population, and 143 were female, which is 62.7% of the population. The median age at the time of operation was 6 months, and at the time of repair, 38.6% had severe mitral regurgitation and 71.4% had severe left ventricular dysfunction. The surgical procedures were coronary reimplantation, which was done in 75.8%, Takeuchi procedure, which is done in 14.9%, ligation in 3.9%, and coronary artery bypass graft in 5.3% of the patients. The in-house hospital death, that is immediate post-op death, it was 31 out of 288 patients, which is about 13.6%. The in-house hospital death, we found that it was not associated with mitral regurgitation severity. And patients with moderate or severe mitral regurgitation, the risk of death was 28% lower when undergoing a mitral valve operation. Infant operation had significant association with increased risk of in-house hospital death. 30-year transplant-free survival among those discharged were 95.5%. There were 6 deaths and 2 transplants. Transplant-free survival at 30 years discharge was 97.6% for patients with severe mitral regurgitation, which is really good. And coronary reimplantation was associated with better survival when compared to other types of surgical techniques. So this is the Kaplan-Meier curve explaining the transplant-free survival plot along with time after discharge. So the x-axis is representing the time since discharge after ALCAPA repair, and the y-axis is representing transplant-free survival. So if we see transplant-free 95%, which is actually underwent ALCAPA repair were able to survive for 30 years, which is really good. And it was also found that there was no association between 30-year transplant-free survival with the degree of pre-operative mitral regurgitation or left ventricular dysfunction. So in this table, if we see the degree of mitral regurgitation and left ventricular dysfunction,
Aishwarya, we can't hear you. There is a voice breaking.
Can there be an improvement?
Hello, sir.
Yeah, we can hear you right now. I think the internet connection is a bit tricky there because I think
Now you can hear.
Yeah.
But Aishwarya, can you
restart?
Let's see what happens.
Now is it audible, sir?
Yeah. Yes.
Though the operative risk is high in infants, they had better long-term outcome due to early restoration of the dual coronary perfusion. So in infants and children, if we see the p-value is less than 0.05, which is significant. So among the patients surviving to discharge, 24 had more than or equal to 1 subsequent cardiac intervention on PCC up to 2011. 9 had pulmonary artery reconstruction. Mitral valve operation was done in 8. Coronary interventions was done in 6, and 2 underwent heart transplantation. So in conclusion, favorable long-term outcomes can be expected after coronary reimplantation in ALCAPA, even in patients with severe mitral regurgitation and left ventricular dysfunction at presentation. Mitral valve operation predicted decreased risk for in-hospital mortality in patients with moderate or severe mitral regurgitation. And mitral regurgitation severity predicted neither in-hospital nor long-term outcomes. Thank you.
Thank you, Aishwarya, for that excellent, crisp presentation. Now, we will hear from Dr. Greeshma. Over to Dr. Greeshma. Can you please start screen sharing?
Good evening, everyone. I am Dr. Greeshma. I will be doing the journal club analysis. So article title, Long-Term Outcomes of Children Operated on for Anomalous Left Coronary Artery from the Pulmonary Artery. I have analyzed this based on the stroke checklist and the CASP, that is a Critical Appraisal Skill Program. This basically consists of, are the results of the study valid? What are the results? And will the result help locally? And based on the stroke checklist, that is strengthening the observational studies in epidemiology. So it is basically, we are seeing that whether they have written the title and abstract, the introduction, whether the backgrounds and objectives are correct, and methods, what was the study design, what are the statistical methods, the results, they have included the main results and other analysis and discussion, whether they have said the key results, limitation, interpretation, and generalizability, and other information like funding. So when we see the title, yes, title is reflective of the study question and the study outcome, and the study population also mentioned. But could be better, the study design is not mentioned in the title. Here we can see long-term outcome of children operated on for anomalous left coronary artery from pulmonary artery. It is a retrospective cohort study. So the study design is not mentioned. That tells the weightage of that study. Abstract is well structured with background, method, results, and conclusions clearly mentioned. Specific objectives mentioned. It is the long-term transplant-free survival and prognostic indicators after surgical repair for ALCAPA in children less than 18 years enrolled in Pediatric Cardiac Care Consortium. Did the study address a focused and clinically relevant issue? Yes. Being a pediatrician, if a child is coming to us at 2 months of age with features of cardiac failure or LV dysfunction, so we should think that there is a possibility of ALCAPA also other than viral myocarditis. And when we are referring this child to a cardiac center for operation, the study clearly tells that there is a transplant-free, 30-year transplant-free survival of 95.5%. So this is a clinical, they have focused and answer a clinically relevant issue. So methodology, it is a retrospective cohort study. Have done multi-centric study. That is very important here. So around 47 good US centers, the cardiac surgeries are included in this PCCC. And it will eliminate a lot of bias, because if it is from the other studies which was done earlier are from a single center study. So if they're in that center, if more they are preferred reimplantation or a Takeuchi procedure, they will tell about that procedure more. But this is a multi-centric study, and they have done with multivariate analysis. That is, combined risk of multiple risk factors are analyzed together. So this, we all know this picture. That is the epidemiological study. Ours is cohort study, which is an analytical observational study. When we see the weightage of study, cohort study comes less than the statistical review or meta-analysis and RCT. But this study, even though it is a cohort study, ALCAPA, which is a rare condition, 1 in 3 lakh is the incidence. So they have done with a larger sample size and long-term follow-up of 30 years. So this study has its own weightage. So cohort is a group of people with sameness, as this Roman soldiers with sameness. So here our cohort is patient who underwent ALCAPA repair before age 18 years at various pediatric cardiac care centers, which were included in this consortium. So methodology, it is very clear. It is a data from a registry they have taken. So they have linked the patient who underwent ALCAPA repair between 1982 and 2003 in the PCC with the National Death Index and the OPTN, that is Organ Procurement and Transplantation Network. They examine their outcome through 2019. So good thing is longer follow-up time and multi-center in nature. So it gives a pragmatic view of outcomes in contrast to previous studies from a single tertiary centers. So as already Aishwarya said, Dr. Aiswarya said, study flow. So which has the 330 children were included in the PCC. So and only 228 were eligible, this NDA eligible patients. And out of this 330, they could analyze only 177 children. So only 60% of these children were analyzed. If the other link, we don't know the follow-up also. So if that was also included, the outcome may change. So in this 177, 22 in-hospital death was there, which is mainly seen with infants, and the death was 13.6%. But when we see the long-term outcome, which was around 95.5%. That's a larger sample size compared to other studies, but they have not mentioned the sample size calculation. But since it's taken from a registry, the sample size calculation is not needed. And they have done the statistical analysis. The comparisons of categorical characteristics were performed using chi-square test, and median across groups were compared with Wilcox and rank-sum test. So this is important slide. So we can see the results. So overall, 177 children were underwent surgery. In that, in-hospital death were for 22 children. And post-discharge, 6 death and 2 transplant, total 8 post-discharge events were there. So we can see that age group, they have divided into infants less than 1 year and child 1 to 17 years. So all these 22 deaths were in infant group. And in the child group, no death was there. But the thing is, the median age of surgery was here at 6 months. And as Sufi sir already told us that less than 1 year, if surgery is not done, survival is only less than 10%. And the era of intervention, early, they were divided into early, middle, and late. As we can see here, the late, that is 2000 to 2003 intervention, only less than 3 deaths were there. That may be because of the good expertise. And coming to the type of operation, this is also important. The type reimplantation is the preferred technique. And here 136 are underwent reimplantation, and the long-term survival was good for reimplantation. And about degree of mitral regurgitation. So they have divided into mild, moderate, and severe. So those children who had mild mitral regurgitation, the in-hospital death was 13, and post-discharge death was 6. Death was 3. So the degree of MR does not affect the long-term survival, though p-value was not significant. Then this is also important. Left ventricular dysfunction. You can see severe left ventricular dysfunction, 99 babies had. In that, 17 deaths were there. So this clearly explains why this 22 death happened. Those out of that 22 deaths, 17 had severe LV dysfunction. So the Kaplan-Meier graph, which shows the x-axis of time since discharge after ALCAPA repair and transplant-free survival in the y-axis. So it is around 90%. So we can explain to the patient also. So the survival is good, and this shaded area tells the 95% confidence interval. So transplant-free survival at 30 years after discharge for MR, severe MR, which is 97.6%, and non-severe, which is 93.1%. The p-value was not significant. There was no significant difference in overall survival among the subgroup with different degrees of MR or LV dysfunction. 8 post-discharge events were there, 3 deaths due to cardiovascular cause, 3 unrelated deaths, and 2 heart transplant. The operation in infants is associated with a lower risk of post-discharge death. And re-intervention, 24 had more than or equal to 1 subsequent cardiac intervention. So the 30-year survival for re-implantation was 86.1%, and Takeuchi procedure was 69.9%, and re-implantation is the preferred one. In the discussion, they have clearly mentioned the key result, the strength and limitation of the study, and comparison with other studies and the generalizability. When we see that, our study, that is the Thomas A.S. et al. Study, which is a multicentric study. This is the only multicentric study. Then we have the Mushraf et al. The study from Amrita, that is done from 2005 to 2012 in Amrita Cochin. In that, they have 53 children were analyzed, and we can see the ejection fraction, which is increased from 36.5 to 53.7% after the surgery, after 5 months of review. And the follow-up, our study was having the long-term follow-up. Similar to other study, Lane et al. Has done a study from 1977 to 2002 for 40 years. The sample size was 56, but it was a single center study, and the 20-year survival was 84%. Overall, this is a multi-centric study, and with a long follow-up, and generalizability is like now population. If the center, the expertise are good, if cardiac operations are happening like that, we can extrapolate. Like in Amrita, the study cohort is there. And about strength and limitations of study, longer follow-up time, larger sample size and multi-center was the strength of study. And limitation, it is basically from the registry. So, and retrospective in nature, the preoperative clinical instability of the patients and details of intraoperative findings, we don't know. And patient received later care at center outside PCC also won't be there. And this is also important, quality of life. Since it's taken from registry, we don't know what was the quality of these children who survived. Whether they were included in sports, whether they got married, we don't know. No telephonic interview or anything has happened. So that is a limitation of the study. Overall impression is a large sample size and multi-centric long follow-up. And what I understood is the take-home immediate data after surgery is 13.6%, but long-term survival is 95.5%. Thank you.
Excellent presentation, Dr. Greeshma. Thank you so much. You brought out all the nuances, all the, what are things that we should look for. You have looked for how to point out each and everything, like you have analyzed it beautifully. Now, let us know whether the experts are also thinking like us. So I would like to request Dr. Ramankutty sir to share his thoughts regarding this article. Over to Dr. Ramankutty sir.
Thank you. Am I audible?
Yes, sir. Yes, sir.
Okay, I see this as far as I'm concerned, from looking at from a methodology perspective, this is a very straightforward study. There is no complication. It's a retrospective cohort, as has been explained by the presenters. What I would like you to note is that a retrospective cohort is possible only if you have very good documentation. Here they had they have combined 3 databases. That is, one is at PCC, whatever it is, and then you have the death registry, and then you have something else, right? So see, you have to track the patient through 3 databases. So you need particular identifiers. Identifiers doesn't mean that you should have the exact address and all that, but there should be some kind of way to identify the patient through each 3 databases. So that is the strength of their system, which unfortunately we don't have. I think that is something which we should all note. Retrospective studies are possible only if you have such good data collection documentation systems. And of course, otherwise what will happen is, if you are depending on people's own memory, then there is a lot of bias likely to creep in. Now, one of the, I think Dr. Greeshma suggested that retrospective study might be liable to biases, which is true in the common use of the term. But in case you have very pakka documentation, it is not a problem. So that is something you have to note. When you have very good documentation, it becomes watertight. So that is what they have done. And this retrospective cohort is a very good design for what we call natural history of disease studies. And this is exactly what I see it as, a natural history of disease study. And the evidence pyramid, as far as it goes, is very particular for commenting on whether an intervention is effective or efficacious or not. But here, I don't think that is their aim. It is basically to describe the natural course of the disease of people who, I mean, infants who have been operated and survived the early period. That is, they did not die during the first few days of hospitalization. They had the surgery. So post-surgery, they have come out. And then what happened? So that is exactly their research question. And for that, I think they have put a very good prognosis, as you can see. And of course, about the methodology, I don't think you can find any, I mean, I don't think of course, in anything you can pick holes, but by and large, this is a very well done study and well written up study also. That is what I feel. Basically, so what I would like you to remember is that it is a natural history study. And natural history studies, you need a cohort design. And that is the strength of the cohort design, is that you can actually describe the natural history of a disease using a cohort design. But unfortunately, prospective cohort is very difficult because you cannot, sometimes you may die before the cohort, 30 years means it's a long time. So you have to depend on retrospective cohorts. And retrospective cohorts are possible only in a situation where you have very good documentation like this one. So if you have that, you can do. And now you see a lot of such cohorts coming up. There is like the UK Biobank. There are so many other things. Even in India, there are cohorts which have been initiated for various reasons. I mean, mostly these are in adults, but not in pediatrics. But so if you can, in these days, when databases and very good. I mean, like you said, it's a multi-centric study, but they did not have the trouble of actually combining. I mean, they didn't have the same protocol in the different hospitals or anything, but they just took the data. So that is the strength of the study. They were able to do that. Of course, I assume that they would need several permissions and this and that, but that of course is there. But even in spite of that, they have been able to do that. And I think that in that way, it is a very good attempt. And about the clinical aspects, of course, you are far better to comment than. But what I feel is that, what they have said is that this procedure actually, I mean, you have almost complete survival for most of the more than 95% are surviving to 30 years, whatever. So, but not, I mean, such a serious condition. What more can you expect? So only thing I would like to ask my colleague, especially Dr. Zulfi, is that what is the situation in our kind of place where do they survive like this? Is the surgery common? Is it usually offered? I mean, this is out of curiosity. I just not because of, I just want to know, because it's a very interesting paper, and I found it as basically, my basic training is in pediatrics, and I always very often I regret that I moved away from pediatrics, but well, there's no going back. So
and can I?
Yes, sir. Yes, sir. Zulfikar, can
because otherwise I might forget to answer Ramankutty's relevant question. See, you have said this 1 in 300,000 is the incidence, which means you have 10 babies with congenital heart disease out of 1,000 deliveries, which means it's a very rare condition. It comes only in among congenital heart disease. It is only in 1 in 3,000. Put it very simply. So it's very rare. But we do regularly see in larger hospitals. We do regularly see ALCAPA. They usually masquerade as DCM, even though we talk about angina symptoms or incessant cry as an important manifestation. Practically almost all, a little bit anecdotal, of course, practically almost all ALCAPAs diagnosed by us are basically they presented with the so-called dilated cardiomyopathy. And now I think in the 90s, many of the centers in India used to do Takeuchi surgery primarily, which is not an absolute surgery. The current anatomical and physiological surgery, as you know, is a coronary reimplantation. That came in mainly because they had success in arterial switch operation. Nowadays, practically almost big centers, larger centers like Chitra, Amrita, Escorts, All India Institute, PGA, all those, Chennai also, they practically do the coronary reimplantation, which is, of course, definitely better survival and a better long-term LV function also. So currently, because when I was doing my DM in the 90s, I used to witness Takeuchi being done. But now practically almost everybody, all are doing coronary implantation. And again, we don't have real data, regular data, but for almost all babies who have survived the surgery, I think they're doing very well with a near normal LV function. They do very well in terms of LV function. Some of them have mild to moderate MR, which probably could be managed medically. So the number of, redo surgeries are not very high. So they do very well. I mean, generally we talk about 3 very important congenital heart disease which have excellent long-term outlook. That is tetralogy, TGA, and TAPVC. So I think after that, I think ALCAPA could be put in. Especially with this data, it's a very interesting data. Another practical point in this data is that among these cohort, those who have survived after 5 years after the surgery, nobody had died. So that is a very interesting thing, because in tetralogy and TGA, what happens is that for the first 20 years will be very smooth going. Then somewhere between 25 years to 35 years, there may be occasional episodes of sudden cardiac death, which is, is a tragic thing, suddenly unexplained and traumatic for the family. But here is a situation where those babies who die, they die primarily in the peri-operative period in hospital. And those who survive hospital, I mean, when you go out of this hospital, 95% survived for 30 years. And ones who have crossed 5 years, that kind of Lakshmana Rekha, in this study at least, nobody died. So that is again indicating a very a very good outlook in terms of long term. That would be very reassuring to the parents.
Can I ask one question in between?
Yes, sir.
One straight question, Dr. Sulfi. How many patients in your follow-up are there who have been operated and are doing well? That's number one.
Yes.
Number two is I find that a good number of children have not been operated in infancy, even in this study. When am I to understand that some of these ALCAPA patients would come up in later age, in 2 years, 3 years, and it could still be ALCAPA and not having much of symptoms? That is number two. Now, the most important question is this, because I had a talk with you and I was really surprised about 10 years ago, you casually told me some cases of myocarditis, dilated cardiomyopathy, when you do an echo, it turns out to be ALCAPA. And therefore, every case I see dilated cardiomyopathy, the echocardiogram is difficult to get, and it is often done by the adult cardiologist. Even now, it is difficult. In Trivandrum, it might be difficult. In Gulf, it was almost always there. And they used to write at the bottom of the sign, done by an adult cardiologist, but better take the opinion of a pediatric cardiologist. Therefore, are we to get an opinion of a pediatric cardiologist for all dilated cardiomyopathy and myocarditis? Did I go?
Yeah, 3 questions. No, we'll start with the last question.
Yeah.
I think one of the very good things in Kerala nowadays is that practically all pediatric, everybody in the pediatric community know that if you have a LV dysfunction, what we call as euphemistically called as dilated cardiomyopathy below 1 year, we must rule out 3 things at least: ALCAPA, aortic stenosis, and coarctation. I think that is the reason why we pick up ALCAPA much early, especially in Kerala, I feel, definitely feel.
Yeah.
The second thing is that ALCAPA, my experience on ALCAPA, because basically my experience starts from Chitra. Then later on, I am following up many of the ALCAPA who were operated either in Chitra or in Amrita. So it's again, of course, anecdotal, but majority, maybe 9 out of 10 babies who had underwent this one, coronary reimplantation, are doing excellently well with a near normal LV function, only mild MR. They're doing very well, actually. But the point is, this ALCAPA surgery reimplantation probably started somewhere in the mid-90s. So that means that we have around adults, young adults, approximately 25 years old. We don't have data beyond that in Kerala, but they're doing very well. Even Takeuchi procedure, they seem to be doing very well. And the third question is that infancy and ALCAPA. See, the interesting thing is that the survival of infants without surgery beyond 1 year depends on two things. One is extensive collateral. Some of them will have extensive collaterals. They will have a chronic ischemia. They will develop a MR, progressive MR. They will behave like an MR with a mild LV dysfunction, and they would survive beyond 1 year. So those are the ones which we see. See, here the mean age was 6 months, but the range was from some 2 months to 16 years, I suppose. Aishwarya, the oldest was some 16 years. And in Medical College Trivandrum, we had one 32-year-old lady who was followed up as a rheumatic MR. And one fine morning, let's say, because it is fine morning for her definitely, because people found out it was an ALCAPA and operated by Takeuchi, and she is doing very well. Now she must be somewhere in the middle 40s. So there is a one subgroup of hemodynamically interesting population. Because of the extensive collaterals in the beginning itself, they continue to survive with a low-grade ischemia, and then they will develop MR. So they will present like an MR. So those are the ones which will survive after 1 year. Otherwise, they succumb.
How difficult it is to diagnose on echo?
Yeah, it is. I think it is. I think two important diseases for pediatric cardiologists to miss is one is this ALCAPA, another is TAPVC. But probably ALCAPA is a little more difficult because TAPVC, at least you do a 4-chamber view, you find that the left atrium is very small, etc. Then you can always have a colleague's opinion, and then they will come and some of them will pick up a TAPVC. Whereas DCM, unless you go on persistently, because in fact, from my own experience, whenever I find a DCM below 1 year or so, and I do an echo, I make sure that there is a LCF from the aorta. But next visit also, I surreptitiously again look for this thing because I don't want to miss a ALCAPA. Practically, let me honestly tell you, almost all pediatric cardiologists would have missed ALCAPA during their lifetime. But when you become more and more experienced, you tend to miss much less. And when in doubt, always ask. That is a very important thing. When in doubt, you always ask another person, even though that person may be much junior to you. That is, I think, that's a very important lesson. Everybody, not only in cardiology, but in all areas. See, for example, I have a problem with diagnosing. I am in two minds regarding ALCAPA or a TAPVC. I would basically ask one or two pediatric cardiologists in Chitra who were my erstwhile students. So, that way, I think it's very important. When actually people, both ALCAPA and TAPVC, this is far, I'm going away from the scientific aspect of this research, but I am saying that these are the two things which teach you humility. You can miss and you have to continue to strive not to miss. And it is a very good result also, excellent result.
Yeah, because many times nowadays we are getting infants with dilated heart, dilated coronaries, and we think it is post-COVID and it was missed and all those things. At all those times I had this worry that whether we are missing something else. Because now it is presumed that it was patient probably had a latent COVID and the result of it we are seeing now. We are also seeing patients and not very, even in a PRS hospital, 2 patients in shock who later turned out to be cardiogenic shock. And we have all, without any evidence, we have said it is missed and probably nothing else. But I often wonder whether something is getting missed. That's why this question, sir. Thank you very much.
Then one more point I think I just want to add is that, see, over the last 20 years, from 80s to 2000, I suppose, things have become much better now. Even in ALCAPA, maybe the mortality, I had to check, must be less than 10 nowadays, because you can see the third group between 1999 and 2003, the mortality came down to less than 10%. It was 13.6 and came down to less than 10%. Maybe it is less now. But the point is, the other major complex heart disease like TGA, etc., TAPVC, the mortality has, post-operative mortality has dramatically become less than 2, less than 3 and out. Petrology, practically nobody dies. But that kind of rapid decline in the in-hospital mortality is not seen in ALCAPA.
Why is the mortality high in infants immediately?
Yeah, because maybe there is a bias of survival, because those people who present to you with severe LV dysfunction are those ones who don't have good collaterals, and it may not be an RCA, it may be a LCA dominant, because you have two types of physiology in the coronary circulation. You have an LCA dominant, LAD dominant situation where practically everything is supplied by the left system, whereas a dominant RCA system where it takes a more share of the supply. So that may be another reason. Suppose you have an RCA dominant system, things may be better for survival. But you must remember that the mortality, 1 year mortality, natural history of a ALCAPA is equal to or worse than TGA, because you consider TGA as one of the most mortal of the congenital heart disease.
Yeah, I think that is very important, because there is definitely a survival bias. I mean, they are following up infants who have survived. So, right. I mean, that is the point. So, the initial part is different. I mean,
different.
Initial mortality is high. So,
very high. That
the
is the
point is that once you survive that period, then there is a definitely, prognosis is good. And that is what I think Zulfi also mentioned, that in some of the other conditions, even after survival in the early period, you might get sudden death.
Yeah, sudden death, which is
the point that clinically, I think that is the most important point.
It's a very important practical point, because you reach your 30s and early 40s and you die, whereas ALCAPA, they seem to do very well. But another very interesting thing is that ultimately the good result, excellent results, long-term results of ALCAPA came mainly because people had a very good surgery like arterial switch operation, because till that time it's very difficult for them to stitch in a 2 millimeter, 1.5 millimeter in a 3 kilogram child to a aorta. So I think those people.
Actually, I was wondering how it is done. It's really remarkable.
It's remarkable. It's a remarkable procedure. Once, because if you watch an adult cardiac surgeon doing a CABG, that is also looks very difficult. But they are talking about a 3.5 millimeter coronary artery being stitched to a 4 millimeter internal thoracic artery. Whereas here you have a 3 kilogram child. That would be a 70 kilogram adult. You have a 3 kilogram child and you have 1.7, 1.5 millimeter being stitched to. It's a wonderful thing. I think that is why Dr. Cherian used to say that pediatric cardiac surgery divides people into ordinary surgeons and extraordinary surgeons. So he feels that being a
I think they are very much underappreciated. That is another thing.
Yes, very much.
Go after the ones who do the bypass in the adults and all that. But I think these are the people who.
These are the people. Yeah, exactly, precisely.
Our hat off. Yeah, correct.
Thank you, sir. I think it is time for queries and other discussions. So if
I thank my postgraduates there. I think Anju, you must agree that our postgraduates, without any help from me, I have not even spoke to them about this. I just gave them the article, and
so he had a dry run.
Excellent.
I appreciate their. I somehow learned something from Greeshma regarding this analysis of one, because usually my teacher is Ramankutty, but anyway.
Sir Purushothaman sir, we would like to hear from you, sir.
Great. That is a learning experience. Can you?
Yes, sir.
You can hear. You can hear.
That is a great learning experience for me. In fact, I expected this. And Aiswarya and Greeshma definitely, as Zulfikar said, that is a wonderful job you did. And a few comments about the Greeshma's comments itself. The quality of life of these 30 years surviving people, whether it's just a number, that much numbers survived. Are they having any angina? Are they having any problems? And that should have been looked for.
Yeah.
And of course, as sir said, 5 years and after that, because Zulfikar was just telling now 1.7 millimeter coronary. It is I think it's a button of the vessels around the coronary. That's a very good thing.
But still, it's a very difficult process.
Yes, sir. Yes, sir. The stenosis part is very unlikely unless unlike the situation of a Kawasaki, where the abnormal coronary vessel wall is being followed up. This is the entire coronary with the button transplanted. And if there are no problems, of course, after 5 years, long-term survival is guaranteed. That is one advantage. Sir, so sir, one question. Is it the very same difficulty or a little more difficulty compared to the Jetin's procedure? Because in Jetin, you are cutting and you are getting a better window for the button transfer. And here, the in between the arteries, you have to do this thing, a little bit more difficult procedure.
Yeah, but technically, because in DTGA arterial, there is a Leconte manual, which the surgeons do, where you dissect out and put in the coronary, because you have to put in 2 coronary arteries. Here you have to only put one coronary artery. That is one advantage. Second advantage is that in an ASO, we are dealing with a 2.5 to 3 kilogram baby, whereas the mean, as you can see in the paper, the mean weight of the child would be around 6 kilogram, 5 kilogram. So in that way, coronary may be little bigger. But you must remember, Purushothaman, that we somehow see more of coronary ostial narrowing in post-ASO procedure than in ALCAPA. That's a very interesting thing. Because one of the major problems of an arterial switch, one is definitely aortic regurgitation, what you call as a neo-aortic. Second is actually ostial stenosis can produce an MI or a sudden cardiac death. But somehow that is the interesting thing. That is, in ALCAPA, if you survive the first few months or years, they tend to do very well. They don't have this late ostial stenosis, no, that kind. But they continue to have some MR, that some of the MR may progress to severe MR. It may require a mitral valve repair. That is there, which I think Aishwarya has mentioned those redo procedures. They have mentioned about pulmonary artery procedures also. That is because that is in Takeuchi, because Takeuchi will deform the pulmonary artery, because you are putting a baffle through the pulmonary artery. There may be a deformity problem. So then they have to do the some reconstruction of the pulmonary. So that is that.
Sir, about the Padmanabhan sir question, I think what way this study is relevant for us. One thing is, last month we had a case of ALCAPA. By the time they reached Amrita Hospital, it was already delayed and we couldn't save the child in spite of sending to a heart center. So in Kerala scenario, what lesson we learned from all these things is, we should be having a system to diagnose early, and the intervention center. The time gap matters a lot still in Kerala. And of course, Padmanabhan sir's suggestion need to be considered about any DCM in an older person. The coronary anatomy need to be checked by a pediatric cardiologist, because they are the coronary missing by the adult cardiologist is much high.
Yeah, even though I am a stakeholder in this, what I would say is that any baby below 1 year with a so-called dilated cardiomyopathy, we have to have a pediatric cardiology opinion. All right, that is, I think, the must. I think definitely that will improve the, getting into this. And early referral, as Purushothaman was saying.
Sir, Ramankutty sir, one research methodology question. When there are more and more of improvement in the techniques and the care from 80s to 2000 to 2019, and the techniques is different. Initially, CABG was 5%. You did the Takeuchi's procedure, later the best procedure, and the care was also better. That is shown in this case. If there are multiple, in a case of retrospective cohort study, there are multiple techniques involved and the care level differs a lot, what way that will affect this sort of a retrospective cohort study, sir?
Oh, that is
definitely that's a problem. I think that's a very good point.
Very good. I mean, that's a very good point.
over 30 years, in a place like USA, the kind of treatment changes a lot. And but then the thing is that is what I mentioned, that this is like a natural history study. So it actually kind of incorporates that into the study. So that's what they're saying, is that in spite of all that, they still have such a high survival. And in that context, I would also like to comment on your earlier point, that the quality of life. But the point is that, this is, I think, I don't know how many people realize that this is probably as I understand it, the study completely done from records. They have not contacted any patient. So it's very difficult to do a quality of life assessment from records, because unless you contact the patient, so
I think they have mentioned that also, I think, at the end of the article. I think they're deficient, one of the deficiencies, so-called deficiency they have mentioned.
So that is what I emphasize, that, unless you have very good recording, documenting systems, you cannot do this kind of a study. So that is also one of the lessons from this.
Sir, sorry for interfering, sir. There is one question in the chat box. Does the stoma of coronary anastomosis grow with the child?
Stoma? Yeah. Yes.
That was question.
Because, basically we have previous experience of BT shunt. If you do a BT shunt, I think the stoma grows with this.
Yes, sir.
Even pulmonary artery grows, no? So it grows.
Sir, I have one query to Ramankutty, sir. Actually, it is not a query. Actually, I was just asking the doubt. Like, sir, we have been searching about the statistics of this ALCAPA from India and all during our preliminary discussions and all. So, sir, we know that everybody wants a registry, want to keep and all. So, sir, what are the practical difficulties that a person usually, in a institution like Srijitra and all, what are the practical difficulties that one will face when such registries are tried to be maintained, sir? Because if we have a registry, we can follow up the children. The rare diseases are there. So can you please comment on that, sir?
Yeah, definitely. One of the problems with the registries is that every hospital should be prepared to send the details to you or send the patient to you, which of course it's very difficult. But I remember two things. One is, I think when Dr. Radhakrishnan was there as a, the neurologist, he was the director. He started a registry for, what is that? What is the complication of measles? I'm completely forgotten.
SSP, sir. SSP.
He had a registry for I'm very, very sorry. I should not have said this in a forum.
It's okay, sir. We'll cut it.
In fact, my case for the one of the different diagnoses for the long case for the MD exam. So I should not have forgotten that. But my point is that they had a registry, but his difficulty was that you don't know what happens in all the hospitals. People may come and they may not report, and so it's becomes a kind of incomplete registry unless you have some system where you have a very definite.
Sir, shouldn't the government be keen enough to maintain such registries and all? Because when previously the Zika virus infection came, then everybody was running around keeping registries, starting registries, things
so
like
in that way, I think what Dr. Harikrishnan, I think now has a registry for heart failure, that is mainly adults, I think. But he's doing better because I think it's supported by ICMR and there are instructions. People are sending all the patients or at least details of the patients. So he's doing, and I think that is probably will be a good database. So this registry, this is the difficulty. In fact, I think I remember the first registry in Srijitra was the endomyocardial fibrosis
EMF registry.
Dr. Vilethan started, and of course that's a very rare condition, and then he could actually influence people to send all the patients to Chitra, and I think it even then I don't know whether it was complete, but it was at least a very good attempt. So it's not an easy thing, but I think things like people but what I am also surprised is that set up like USA, where there are a lot of private hospitals and all, they still did this. I could have imagined, or I could have believed it better if it happens in NHS in UK, because you have one system and you can easily say please send all the details to one center. But even in a multi kind of environment like USA, where there are a lot of private hospitals, they still did it. It's quite impressive.
I think working in the Gulf for many years, I can tell you they are moving towards having a single number for the patient has only one number. Anywhere he goes, all the computers are linked. Therefore, automatically we know each other. Now, therefore, they are moving. Therefore, if Kerala, I also heard that they are going to have what they call a single number for the OPD number for the patient.
It is there, sir. It is there.
Yes, there is an initiative for
e-health
e-health,
programs,
but I don't know how far. But I think it's a very good initiative. I hope it grows into a big.
But you know, it should be the same number in say Fort Hospital. Where,
yeah, it is like that only, sir.
And same number in the medical college when he goes. It should be linked. Therefore, you can see the other. Then you can get the registry of everything very fast.
Sir, one more
question is there. Will be a dilated cardiomyopathy. I mean, basically the question is whether the severe LV dysfunction which occurs in ALCAPA revert to normal after surgery. Definitely yes. Majority will become near normal or normal. MR will become less. Basically because unless the patient has gone in for a myocardial infarction, majority will go for a severe ischemia and ischemic cardiomyopathy and sort of a hibernating myocardium. So once the two coronary circulation is regained, they will definitely improve. LV function will become normal in majority.
Sir, thank you, sir.
Okay.
Sir, if there are no, it is already 8:48, sir.
8:40.
So if there are no other comments or something, then we will probably think of finding it up. But I see Dr. Vijay Kumar sir, the audience is the Vijay Kumar sir, sir, unmute samsarikana sir. Vijay Kumar sir. I think sir is not there actually. Okay.
Let's not waken up the sleeping giant.
Sir, actually Premila Joji madam was there because we wanted to extend our sincere thanks to KIMSHEALTH and the people from the KIMS because there was an excellent job actually. And sir, can we wind up, sir, if there are no other questions? Sir?
I'll just add one small thing that the PGs presented fantastically, but I would like to point out that Anju Kanmani had a dry run on this 2 days back. And he made many suggestions. And all the three things he has been very, very sincere, in fact, over sincere. 2 days ago, all this we have a dry run. And,
I see.
we dry run and we make sure that it's one of the aims of this is also to make sure our PGs are not like us. You know, they are more, they can talk better. They don't have any fear of anything. And that's what I find. That's the aim of another thing. Next time we are looking at we are giving opportunity to all the hospitals. It's not an SAT hospital centric. Now KIMS, now PRS, poor PRS started. And now we will go to Gokulam and we will go to Cosmo. We want all the PGs to come up. That's one of the aims.
So shall I go to the, routine vote of thanks or something, sir? Please. So, sir, join we are so thankful, sir, for joining Purushottam, sir, actually. And regarding this, Zulfi, sir, really, like the old story of the piece of stone with a person. He goes to the diamond merchant and he finds that it's actually a diamond, and the diamond merchant can only find the worth of that. Like that, there's an article and everything. It was uncommon, ഒരു ആർട്ടിക്കിൾ മാത്രമേ ഉണ്ടായിരുന്നുള്ളൂ. പക്ഷെ അതിനകത്ത് ഇത്രയും കാര്യങ്ങൾ ഉണ്ടെന്നുള്ളതും അതുപോലെ തന്നെ ആൽക്കാപ്പയെ കുറിച്ച് സാർ ആൽക്കാപ്പ സാറ് തന്നെ നമ്മൾക്ക് വളരെ റെയർ ആണെങ്കിലും നമ്മളൊക്കെ ചെസ്റ്റ് പെയിൻ വളരെ കോമൺ ആയിട്ട് എല്ലാവരും കാണുന്ന സംഗതിയാണ്. ഇപ്പം വളരെ ഇമ്പോർട്ടന്റ് ആയിട്ട് പുഷോ സാറൊക്കെ പറയണ്ടായി, ലൈക്ക് ഒരു DCM വരുമ്പോഴത്തേക്ക് നമ്മൾ ആൽക്കാപ്പയെ കുറിച്ച് ചിന്തിക്കണം എന്നുള്ള ആക്ച്വലി അതൊരു സൂപ്പർ സ്പെഷ്യാലിറ്റി ലെവലിലുള്ള ഒരു കൺക്ലൂഷൻ ആണ്. അപ്പം എനിവേ I would like to thank all the persons who were involved in the journal club, especially our teacher Dr. Zulfikar Ahamed sir. Thank you, sir. വിളിച്ചപ്പോൾ തന്നെ സാറ് വളരെ ഇൻട്രസ്റ്റഡ് ആയിട്ട് ആർട്ടിക്കിൾ
I was actually so happy that Padmanabhan initiated this very interesting because he has made this one an attractive thing.
Sir, Then again, Purushothaman sir, Zulfikar sir, Ramankutty sir, thank you so much, sir. Sarna idakku vilichappothekku njan sarnodu paranayirunnu parnallo sir, sarinte level nalladana enna kuda manasalathakku പക്ഷേ sir has I mean sir അതുപോലെ കംപ്ലീറ്റ് കൂടെ കാണണം എന്തായാലും sir ഉണ്ടായി പറ്റുള്ളൂ എന്ന് പറഞ്ഞു sir അതുപോലെ തന്നെ ഞങ്ങളുടെ കൂടെ ഉണ്ടായിരുന്നു. Thank you so much sir for the patience and the time. And Padmanabhan sir, thank you sir, you are our guide and all. And thanks Ashwathi and Greeshma and all the PGs, teachers, colleagues who have joined. Zulfi sir, thank you so much sir. Can we call today?
Yeah.
Nice day, sir.
Okay, bye. Bye.
Okay.
Take care,
Purishu,
sir.
bye. Purushothaman.
Thank you sir.
So I will leave. Yeah.
Sir.
Thank you.